We have case number 58 now. And Jan is ready to give the case history. Jan, please go ahead.
Our next patient is a 79-year-old male who suffers from an atrial septal defect. In 1962, he presented with a sinus venosus defect with an anomalous right upper pulmonary vein, which was treated with a surgical closure. 5 days after that, he experienced a thrombosis of the right upper pulmonary vein with pulmonary infarction, which required a lobectomy. In the recent few months, he presented with worsened shortness of breath. Past medical history includes hypertension, hyperlipidemia, and bladder cancer, which requires surgery. ECG shows a sinus rhythm with a heart rate of 85 beats per minute and right bundle branch block, furthermore an intermittent Mobitz 1 block. TTE shows a dilated RA and RV with a left to right shunt, moreover pulmonary hypertension with a PA pressure of 47 millimeters of mercury. LV size and function are normal. TEE shows an ASD in the area of fossa ovalis with a flow detected through the ASD. Catheterization shows a PA pressure of 67 over 50 millimeters of mercury. QP to QS equals 1.5. Size of the ASD measured with balloon catheter was 12.9 millimeters. And now back to you, Professor Sievert.
Okay, thank you very much. So this was a very complex history. The key point is this patient had diagnosed a sinus venosus defect in 1962 and underwent surgical closure at that time. And interestingly, he had shown us the surgical report from 1962. And it was amazing at that time, as you may know, at that time there was no echo available. So they made a clinical diagnosis based on EKG, auscultation, and X-ray. And in the report it is written that they opened the chest. They didn't have a pump at that time. So they opened the chest, then they opened the right atrial appendage, and the surgeon described that he inserted his finger into the right atrium and made the diagnosis of a sinus venosus defect, and then decided to move ahead and close this. So then what they did, they opened the right atrium, they clamped the superior vena cava and the inferior vena cava because they did not have a pump. So they closed this. They gave something to arrest the heart, cooled the patient down to 21 degrees or something like that, and then confirmed the diagnosis of sinus venosus defect. And what they did is they also found right upper pulmonary vein ending up in the right atrium, which also was diagnosed by the finger of the operator when he went in. And then they sutured the orifice of the right upper pulmonary vein to the defect by direct suture. This is a technique which is not used anymore for good reasons, probably because, as you heard, in this patient, he suffered from upper lobe infarction the day or 2 days after the surgical operation. And then they found that the right upper pulmonary vein was thrombosed and they had to do a lobectomy. So it's a very different time perspective how to treat with cardiac malformations at that time. No echo, no pump, and then this procedure, and also the initial procedure was complicated by heart arrest. They had to do resuscitation during the operation, so it was really a difficult thing. So we managed to put in the TE probe. So let's go for the TE probe. And okay, so maybe the audience has changed a little bit. Neil, could you please ask the audience how many of them have closed ASDs?
Okay, you've just asked, so about 50%.
50% on those.
You know, that's like.
And those 50% who had closed ASDs, who has done more than 10 ASDs?
About the same number.
Yeah.
Okay, who has done more than 50 ASDs?
Getting smaller.
Okay, so I can see you actually.
So
Okay,
most
just
of
to-
the
just-
audience, most of the audience, well,
50%.
yeah, half the audience don't seem to have put in devices, but of those who have put in devices, not so many have put in, say, more than 50.
Okay. Okay, just to understand, so we really want to go step by step, as the title of the session is. So now let's look on the echo in the different planes. And Laura is doing the echo. Can you show us what you see there?
Already grayscale imaging on the X-plane. On the left side is the long axis view. On the right side is the orthogonal view. This is a short axis view, and we can see a very thick septum secundum and a large fossa region with an aneurysm. And if I put here color,
Laura,
Yeah?
can you make
yeah,
can you make the image just a bit bigger, please?
a bit bigger from my side, okay?
Like that?
Like that is okay? Is that okay?
Yeah, we like that. Yeah, yeah,
Okay.
yeah.
You're welcome.
So before you continue, Laura,
Yeah.
let's ask Neil. Let's ask those of the attendees who have done 10 to 20 or so. What kind of defect is that?
What do you mean? Whether they're going
mean,
to call
it's
it an ASD or a
It's
PFO?
an ASD,
you
but
mean?
what type of ASD is this?
Oh, I see. Well, I think
Well, we can have a show of hands if you think this is a secundum ASD. We got a few hands up. How about a primum ASD? Can't say we've seen that
Okay,
part of the
primum
septum,
ASD, I
right?
should show you.
Wait.
Is this a
wait,
residual
wait.
sinus
This is-
venosus ASD?
That's my question. Because
that one.
remember, 1962, they closed a sinus venosus defect by suturing the right upper pulmonary vein onto the defect.
almost like a Warden procedure, but it didn't
So-
work
so do you-
anyway
do you
because they
think he-
thrombosed it.
Yeah.
Do you think this defect was present in 1961 or whenever this was done?
Yeah, that's a good point. So I don't know. I'm assuming that they made a wrong diagnosis, and their technique was, without echo, just putting the finger of the surgeon into the heart and figuring out where the defect
Antoinette,
is.
where's Antoinette?
So I think
Also, I'm going to just
yeah.
Antoinette.
So perhaps at that
Oui.
time they just closed the vein and missed the defect that was there?
Because
Or
Well-
is this just the additional PFO / small ASD that was associated with sinus venosus ASD? Sometimes
Laura?
you see that too.
sorry, Laura.
Yeah, Neil?
Laura, we have a comment here from Antoinette Cilliers, came all the way from Johannesburg to make this observation.
Well, I've been told to say that there's bidirectional shunting.
So this is bidirectional shunting?
No, I
That's-
would say though. You are right. So
think
you
there's a
can
little bit of red
you can see some turbulences at this region, but actually, if I skip this, here is a true. I would say the true ISD. Wait a moment. I have to look. Where is there?
What's the patient saturation, Horst?
Yeah, that's what I just asked Julia. It's 95%. So if there is a bidirectional shunt, which is always the case in all ASDs, there's always a little bit going up and down, but it's not relevant.
Could I ask a quick question? I might have missed it at the very start, but have you had a really good look at the rest of the septum and looked at the posterior part of the septum where the pulmonary veins are to make sure there's not an additional defect? Just with the history of that type of closure in the 1960s, is the rest of the septum completely
Yeah.
intact?
Okay, let's start with the four-chamber view. And the reason for the four-chamber view is because that's the best view to exclude septum primum defect. And here you can see that close to the mitral and tricuspid valve, the septum seems to be intact. But to be sure, go up and down a little bit with the TE probe.
Excuse me, Professor Sievert. Does
Yeah.
the patient have the EKG of about 50 years ago? Because if the p-axis is abnormal, so it's strongly in favor of sinus venosus ASD, because in about 30% of cases, the p-wave axis is abnormal in sinus venosus ASD. So if there is any EKG of about 50 years ago and it shows abnormal p-wave axis, it could be very helpful in
That's a good.
diagnosing the type of ASD.
That's a good point. I would have to check the reports from that time. I saw only the surgical report, but not the reports about the non-invasive diagnosis. Maybe he also has it. So it's actually of interest. We should pull this out later, but cannot do this right now. But it's a good point. Yes. Now let's check for the sinus venosus defect.
ECG,
Let's check for the
but
sinus.
it's
sinus
printed on stone, probably, or slate or something.
I mean, Neil, I mean, this was a crude method at that time, but imagine how difficult it was to diagnose even an ASD just by auscultation, and it's amazing. I was really impressed by that, and with all our knowledge, what we know today, if we go back with a time machine to 1962, we would be the foolish, and we would be without any chance to help the patients. Because we cannot bring
I agree.
TE with a time machine back to 1962. Okay, so let's look now for the sinus venosus defect. The best view for the sinus venosus defect is a long axis view, and then Laura will pull back the echo probe towards the superior vena cava to check whether we can see a sinus venosus defect.
Okay, here's the vena, SVC, and here's a right upper pulmonal vein, and I am pulling back and keep on the screen the connection between SVC and right upper pulmonal vein. And now I am advancing the probe a little bit deeper.
No, just pull it out. Better and pull it out and rotate. Yeah, good. And now rotate to both sides. Seems to be that there's no sinus venosus defect. That is a defect we would expect above the septum secundum. So that means on the right side of the septum secundum in this view here. There seems to be no defect. So the question is, and we cannot answer that question, is did they made a correct diagnosis, and did they suture? In the report it's written, we sutured the orifice of the right upper pulmonary vein to the defect, and we were absolutely sure that there was no residual defect. So it could be that they closed the sinus venosus defect and there is an additional septum secundum defect, or they made a false diagnosis and sutured it somewhere, and we just see the original defect here. So that's something I don't know. Do you want to see any other views of the echo?
But they did a right upper lobectomy anyway, you said, sometime afterwards. So
It's not written how they did it, because they just did a thoracotomy. They didn't open the heart again, so they just removed the right lung. Obviously, they sutured all the vessels going to the right upper lung, but that doesn't mean anything, because it still could be that at that time the sinus venosus defect was closed, and just the thrombosed vein was also then closed. So that doesn't really help us in the diagnosis here.
well, yeah, but without the right upper pulmonary vein, it's going to be quite hard to be sure about a superior sinus venosus defect anyway. But never mind.
Yeah.
There is a stump of pulmonary vein there, but I'm not sure we were seeing true flow.
Okay, that's a good point. Can we see the right upper pulmonary vein?
Yes, you can see them on the screen.
Can you
would
point
like
out
to
where
go
it is?
to this?
Yeah, maybe 2D.
Okay, here.
Yeah, you have something there, but
What
It
would you
looks
like?
more like a stump than a vein coming in, doesn't it?
Maybe in short axis. And I mean, there may have been more than one right upper pulmonary vein, so we don't know.
Sure. And a right middle joining
Maybe
it or
getting the
something.
middle.
Yeah, yeah.
Horst, let's get moving.
Yeah, okay. So I think we agree now that this is a septum secundum defect, either not diagnosed at that time or just in addition to the sinus venosus defect. So next step will be to try to cross this defect. Können wir ihn gerade hinlegen? Er liegt so schepp da. Ich habe da ein Problem mit der Optik.
What is that radio opaque?
That's something
shape
which was put in
your
50 years
field?
ago. I don't know what it is, but it is from that prior surgery. One of the surgeries.
We don't have anybody old enough in the audience to ask them if they know what that is.
So he was not
Maybe
operated.
Shaq would know.
He was not operated at the university hospital. It was how is that, a municipal hospital.
So Horst, if we're going step by step, is your typical go-to catheter for crossing ASD or PFO going to be multi-purpose or something else?
Yeah, it's usually multi-purpose. I'm just going to the superior vena cava, pulling down now. Can you show me the long axis view of the septum in 2D? Okay. So I'm still high up there.
What's your next choice after multi-purpose if you weren't able to cross?
It depends upon the position of the defect. You may have seen the case we did earlier, the PFO, where I finally was successful with an IMA catheter. But usually with the multi-purpose, it's not a problem to cross the defect. Actually, I crossed this defect during the diagnostic cath a few days ago, actually. So it shouldn't be too difficult here. Well, it's more difficult for teaching purposes only. I'm too high up. Okay, I'm going down. Now I'm through, I think. Yeah. I tried to go to the superior upper pulmonary vein on the left side, if possible. This is probably the LA.
Some tips for engaging the left upper pulmonary vein?
It's all rotation. So it's rotation when you cross the septum, which is the key. It's not just advancing, especially if you have a floppy septum, like in this case here. If you advance a catheter towards a floppy septum and you are in contact with the septum, then even if you rotate, you just move the septum up and down, but you cannot engage the hole. So it's rotation while you advance the catheter. And the same as when you want to engage the pulmonary vein, it's rotation, not just pushing, but always rotate the catheter. Now, we already did sizing of this defect, so I think if
I could just also add, there's a tendency when you're trying to engage a left upper pulmonary vein, or indeed any of the pulmonary veins, to be anxious about not coming back into the right atrium. But you can usually afford to come back a little further than you think, and when I'm teaching, I would go to the left-hand border of the spine, because there's a tendency to be pushing away, usually engaging the left atrial appendage, or even going down to a lower vein, which isn't a terrible thing, but the left upper is preferred. So come back to the spine, some rotation and advance at the same time.
Good point. So this configuration, what you see now on the screen, is a nice curve in the upper pulmonary branch of the upper pulmonary vein. So this gives the most stable position for either balloon sizing or device deployment. We already did balloon sizing. The diameter was 12.8. So can we go back to the echo images? And I would like to have some suggestions about device type and size.
Okay. So 12.8.
Yeah.
I've just found an Australian. Very experienced Australian.
12.9.
12.9.
Yeah.
Jeff? Jeff Lane here from Melbourne.
Amplatz extra stiff, yes.
Well, I guess first question, given the nature of the septum primum, is whether you're going to balloon size this or whether you're just going to... Oh, a 12 minute, sorry. I'd probably put a 25 millimetre GSO into that.
25 GSO.
Any other suggestions? Okay. Doctor?
No, I don't have an idea about the sizing.
Okay.
Neil,
anybody?
Neil, just on what Jess just said, I wonder whether or not, given the fact that the secundum septum's so fat, if you're going to go with the GSO, whether to try and put a 30 in, just to make sure you get good coverage and splay on the secundum septum if you're going to go with the GSO.
So what would you use as fat criteria for the septum?
Yes.
I know some people measure it. I don't know if it just looks fat, but I haven't actually measured them, no.
What is the thickness? How thick is the septum secundum, Laura?
It seems to be very thick.
Can you measure?
Yeah, very thick, that's what I... Yeah.
That's a centimeter.
It's about a centimeter, right? 9 millimeters.
0.9.
9.06 millimeters.
Well, if it was 9.07, then that might push me to a 30.
Come on, tell us what device you're going to use.
Any other suggestions regarding device type or size?
Yeah, come on, device type and size.
Sizing?
The device sized at 12.9 millimeters. Which device would you like to use? And which size device would you like to use?
I usually use the Amplexer device.
He hasn't done any of these. We've got to help him.
I usually use the Amplexer device.
Which one?
Amplexer.
Mm-hmm. Which size?
Amplexer, yeah.
Yes.
Which size?
What size?
I usually do size according to the sizing balloon size, and usually we just block the hole with no flow. We usually do not oversize too much.
Yeah.
So 12.9.
And we got 12.9. So what size device would you like?
Yeah, maybe a 14 is good. We don't usually oversize a lot.
Mm-hmm. So maybe even 12 then. Horst, we got one suggestion of a 25 GSO, maybe one suggestion of a 30 GSO, a 14 Amplatz, and Dr. Daniels may have.
Can we see the other rims? I think we didn't see adequately all of the rims. Since the posterior rims looks aneurysmatic, and we must also see the AV valve and the other rims to decide to put for the sizing.
Okay, let's go through the different planes.
In this image you can see very well. So, superior rim, inferior rim, and on the other side, anterior rim and anterior rim.
Okay, anything else you want to see? 4-chamber view again?
4-chamber view, okay, 4-chamber view. So, 4-chamber view. Inferior rim. Okay, and superior rim we don't see them.
No, not everybody.
Pictures being taken. I think
The colleague
ASD
who just
closure
asked
in
for
an
these
older
planes. The colleague who asked for these planes, you asked for these images. So what size and device would you use then?
Dr. Kılıç from Turkey, Professor Sievert.
Hi.
I want to use Amplatzer device 14 millimeter because the posterior rim looks aneurysmatic.
Okay. 14 Amplatzer. Okay. So any other suggestions, or is it that?
One more coming.
Can I make a comment about ASD closure in elderly patients? I think we're often concerned by trying to choose a small device because of concern with erosion. But actually in this age group, the prognosis isn't massive anyway, so that's less of a problem. But the bigger problem comes if you get embolization, because these people are multiply comorbid, and retrieving devices in this situation is not without risk. So I would tend to go bigger rather than smaller.
So which size would you recommend?
I'd probably go 16, 18.
That means oversizing by 2 to 4. Okay. Any other suggestions?
To be honest, we put a GSO in this, but if it was going to be an Amplatzer device, I'd go bigger.
Okay. Okay, so GSO is certainly an option. We don't have GSOs available for live cast demonstrations. We will use one of the other devices. Amplatzer is certainly a way to go. We just showed an Amplatzer in the other case there, so we should go for an Occlutech in this case. But we could also use any other Amplatzer-like type devices. I will explain the advantages and specific details of the Occlutech device because the Occlutech device is a little bit softer than the Amplatzer. So with an Amplatzer, I would probably go for 13. Here we'd go for 4. Is 14 available for 15? 13.5 or 15, then let's go for 15. Okay. Occlutech, yeah.
Horst, I had a question. I have one question. It's not about the device, but more about, do you use ever color flow to size the ASD before you do the balloon? Does that ever help you?
We never do this. And the reason is we always start with balloon sizing before we introduce the TEE. And when I have measured the defect with balloon sizing, I think that is, in our hands, most reliable. So we don't do measurements by echo. But it certainly can be done, and maybe others can comment on that.
Let's look at our audience members who are closing ASDs. Are you using color flow or TE sizing, ice sizing, or are you doing balloon sizing? So a show of hands for echo sizing alone. Not too many, or as Neil would say, maybe 95%. 1 or 2. How about stop flow technique with balloon sizing? Okay, majority are doing balloon stop flow technique, Horst.
Okay. Balloon stop flow is, for those of you who are not using it, is to inflate the balloon under echo control and check for residual flow. That is, I think, actually the recommended sizing technique from St. Jude and maybe also from other companies. I never use this. I use the pressure monitored inflation of the balloon. So now let's.
Can I ask you a quick question?
Yeah.
You alluded to it briefly about the Occlutech device and maybe going a bit bigger with an Occlutech compared to an Amplatz. Is it everybody's impression that because the Occlutech's a bit softer, that one, the erosion risk is lower and also the embolization risk is higher, and therefore does everybody slightly oversize the Occlutech devices when they use them?
That's a question to the audience, right?
Occlutech device in the audience. I think there's probably not too many that use Occlutech devices. Is there any country where it's approved other than Germany or Europe? There's some hands there. Would you oversize it if you used it in Occlutech or?
Yes, I come from Belgium. In Belgium, Occlutech is approved for use. And in this patient, I also would oversize the defect depending on the stop flow balloon sizing by 1 to maximum 3 millimeters. The only thing I would personally take into account is in a postoperative setting. So 50 years ago, did they touch the septum in that region or not? Is there a scar tissue or not? And I would also take that into account, because if you would have a lot of scar tissue in that region, then too big oversizing would possibly create a problem in the waist, because indeed the waist of the Occlutech device is a little bit softer, but it doesn't, into my view, it doesn't pop out more easily than other devices, and it's quite easily to deploy.
Okay. So let me comment on the comment from Stefan. I don't know whether anybody from Occlutech is in the audience. They probably got a headache, because Occlutech, I think, is approved everywhere in the world, with the exception of US and Antarctica. So it's worldwide in use. So let me explain the device here. It's looking comparable to the other Amplatzer type devices. The difference to the Amplatzer device is that there is no hub on the left atrial side, so it's has a smooth surface here. And the other side looks also a little bit different because there's no screw. It's a little ball here, which enables us to fix this device to the delivery system. Then you can see that it has a kind of gold coating, which facilitates ingrowth of endothelium or tissue, and may also have less risk of thrombosis formation on the device. So how this can be fixed to the delivery system? The delivery system is has a little capsule at the distal end, and when I pull this or push this knob here, then you can see that a little, let's say, clamp with two arms comes out, and I will push this ball of the device into this clamp. And then release the hub, and then it is fixed. And in order to prevent dislodgement of the device before I want to have it dislodged, I screw it on here. So now the connection between the device and the delivery cable is fixed. And the advantage of that technique compared to a screw is that the connection is flexible. You can see here it's a very flexible connection, which means you can see the device before it is released in a more relaxed status than what is the case with older devices like the Amplatzer. Also, it was the case with the old Occlutech device. So these are the advantages of this particular device. So now let's pull it back into the loading tool. And you can do this underwater, as I'm currently doing here. You can also just pull it in and then flush from the back end of the flushing tool.
First, while you're doing that, we have a couple comments from the audience.
Mm-hmm.
Professor Sievert, as you know, we are using some techniques when during the closure of the complex ASDs,
Mm-hmm.
and like left upper pulmonary technique and the others.
Mm-hmm.
Do you think that these new flex devices prone to some deformities compared to the old Amplatzer device or old series of Occlutech? Because the decreased amount of nitinol wires can be able to be to become deformated, according to my opinion. What do you think about this?
Do you mean deformation during deployment or afterwards?
During, are you talking about Cobra? Well, Cobra head in the left side, specifically?
Okay, so Cobra phenomenon, for those of you not aware of that, is a deformation of the, let's say, Amplatzer type devices, which occurs especially if you have a big sheath. That means an oversized sheath, and that may cause this configuration. And the only thing you can do when you see this is to pull out the device and reload it and re-advance it again, and most often then it works. It's caused by well, entangling of the wires of the device. I don't remember whether I have seen this with the Occlutech devices at all. Has anybody seen Cobra phenomenon with the Occlutech device?
There may be 5 hands up, or yeah.
Okay, so it happens there as well. I don't know whether it's more frequent than with the Amplatzer devices. I don't know.
Excuse me, Professor Sievert. We did a multi-center study in our country with my colleagues, and we had more frequent cases of Cobra head deformity with Occlutech. Without that, it may be because the finer wire mesh in the waist of the device makes it more to be more tendency to Cobra formation. So two things we thought perhaps it would be helpful. The first one is when we wanted to load it, be very careful that it is 100% perpendicular to the level of the sheath, and so proper loading that reduces the rate of twisting at the place of the waist. And the second point that we thought that perhaps it would be helpful, that just make the strength of the nitinol wire mesh at the place of the waist equal to amplatzer, just at that part, because it's a very, very critical point for twisting and making cobra head deformity. It's a suggestion. I don't know what's your valuable point on that.
As I said, I cannot comment that, but I think it's a good input to know that. So the next step will be to exchange the diagnostic catheter, which is in the pulmonary vein, for the delivery sheath, which comes with the device. For this device size, I think it's a 9 French sheath. So in general, for the Occlutech, you need a little bit larger sheath than for the amplatzer device, which is one of the, if you want to say so, one of the disadvantages of the Occlutech compared to the amplatzer, that you need bigger sheath. It's not an issue with in adults, but maybe an issue in smaller children. I don't know. So now I'm advancing. Okay, for exchange, I'm using an Amplatz extra stiff wire with a J-tip and a 3 centimeter long soft tip. And this gives the maximum of stability in the pulmonary vein. I'm pulling out the short 9 French sheath. Okay, the sheath is in. I'm advancing this up to the level of the pulmonary vein. I'm retrieving the dilator and the wire. Now I want to see back bleeding here. Julia asked me to check ACT because we have taken some time here.
I see something. I can see something here on the anterior rim.
Uh-huh.
Something.
What is that? ACT. What do you see?
I would say at this position, like a fluttering. I haven't any idea. It should be a small thrombus or I don't know what is that.
So if you want to know, then go back to the initial images.
Yeah. So do you want 2 sheets?
Do we need TE?
Well, we're using eyes.
Yeah, okay.
Does he want to use eyes?
I think it's a little piece of tissue, but I'm not sure.
In the previous picture I didn't see, but it's not the same position.
Yeah. So I will advance now the device. The problem with these type of devices which do not have a harp on the left atrial side is obviously that there's also no marker, so it's sometimes really difficult to see the distal end of the device. So I move up a little bit. Okay, here it comes. I can see it, but it's probably difficult for you to see it. I will just thin this. Okay, so now the distal end of the device is at the position of the TE probe, and the proximal end is where the marker of the delivery catheter or the delivery system is. Let's go to LAO, please. So now we'll advance it further. Let me zoom in to show you the tip of the device. This is important because if you don't pay attention and just push, you will create a catastrophe because the device is then going out of the sheath without Now you see that it's at the tip of the sheath. So now we are still in the pulmonary vein. So we'll now pull back the device. Can you show us the pulmonary vein, the left upper pulmonary vein, please? So now I will pull back the sheath out of the pulmonary vein. I will do this under fluoro and echo. Now it falls down on fluoro, so I'm assuming that I'm out of the pulmonary vein. Yes, I am. I'm at the orifice of the appendage. Now when I look at the angle between the sheath and the septum, it's already almost perpendicular. But if I want to have it more perpendicular, then I have to rotate it clockwise. So I'm pulling out of the appendage now. And now when I rotate clockwise, you can see that it is more perpendicular. When I rotate counterclockwise, it's more, not really parallel, but yeah, not as perpendicular anymore. So rotation clockwise brings it into a better position. So I have to keep this tension because the sheath wants to rotate back. So I keep this tension here. And now I can start deploying the device. In order to do so, I will just keep the metal where it is. So the distal end of the umbrella will stay there. And I'm pulling back the sheath. And you can now see how the device is opening. Okay, what you see now is that the left atrial disc is quite bulky. Those of you using the Amplatzer, with the Amplatzer it's more flat. And that is because it just came out of the sheath. So when it becomes softer, which means warmer, then it will be more flat like with the Amplatzer device. Any questions, comments so far?
So Horst,
yeah.
So you'll just leave that bulkiness alone and not manipulate it in any way, but as you come back against the atrial septum, and then it will naturally flatten out over time, correct?
It will flatten out over time. What you could do if you don't like it, you could advance it towards the roof of the left atrium. But I think it's unnecessary because even if it stays like that, it's not a concern. So now I'm pulling it back towards the septum. Now it's touching the septum. I feel the resistance and I see it under echo. And at this point, I will keep again the delivery system in place and pull back the sheath. And this will expose the right atrial disc. Now you see that the system is under tension. I have to advance the metal part in order to open the right atrial disc. Okay, now let's check on echo. Actually, I can pull back the delivery system a little bit more.
Some color, please. Color. Slightly oversized, maybe?
Yeah, because we chose the 15 millimeter and the diameter was only 12.9, so it's slightly oversized, correct? Is that a concern, or do you think it's okay?
I think in this context, it's okay.
Mm-hmm. Okay.
Another comment, sorry.
Neil, why do you say it's oversized? How do you see that it's oversized, or what makes you think it's oversized by looking at it?
I think, sorry, it looked oversized to me at delivery when the central waist didn't really fully expand, although there was a little bit of sort of pushing which constituted it slightly better. So it just looked constrained in the waist rather than a very rapid, but that might also be a temperature thing. And it just looks a little bit proud on the septum on both sides, although I accept that will improve. Sorry, there's a question from somebody in the audience.
Yeah, Dr. Sievert, this is more of I guess a more fundamental question. When you were doing the PFO, you pulled back a little bit just to see if there was any tension. With the ASD, do you do that, or there's just a question on my part because of the ASD being a little bit bigger.
Well, you can do this pulling, but not that strongly as with the PFO, because there's a higher risk of just pulling it through. But usually with all these type of devices, when you pull, you feel the resistance. So it's not that you are able to pull it through easily, as it has been the case, for example, with the CardioSeal many years ago, which you just pull through with a little bit of tension. That's not the case here. So when you pull, you feel the resistance, you see the tension, and then you know that you are touching the septum, and then you can deliver the rest of the device. When you look at fluoro now, you can see that the left atrial side has become flatter. And I think the same is the case with echo. Can we see? Yeah, okay. Yeah, it's for sure flatter than before. It's still a little bit, let's say, bulky. But again, this is due to the little bit of oversizing, what we intended to do, and it's not a concern. Any other questions before I release?
Septum a little bit.
Are we happy with this device?
Just a second. Just don't release, Horst. Don't.
No.
Never. Horst,
I would
just
never
a comment
do
because
that.
we talked about it earlier on. The potential benefit here is that you see that there's good angulation between the device and the delivery system because of the ball socket type release mechanism. So you're less likely to get a very, very significant change in angulation between now and release. And with deficient aortic rims and stuff, it allows you to. I think it gives you maybe more reassurance before you release the device that it's not going to embolize.
Well, we could do a little bit tug and pull, and when we release this device, you will see most likely that it will not tilt as a screw device would do, because it's, as you said, it's flexible. There's a flexible connection between the delivery cable and the...
Put your hand up, those of you who've closed ASDs. Yeah, Isabella. Isabella, Professor Sievert's delivered that device in an LAO projection. Is that what you do normally, LAO, or you've got echo? Why not just do it PA?
LAO with cranial.
How much?
25,
Speak
27.
in the microphone. That's all right.
LAO with the cranial
How much
27.
How much LAO?
35.
Okay, so you have no cranial on there. Anybody just do it AP? And what's the point? You've got beautiful echo pictures. Why tilt the image intensifier? Anybody? Anybody do it AP? Yep, we've got at least 90% who'd prefer to just deliver it in the AP projection. But you choose LAO. You've done that all your life, I think.
Yeah, I see.
Who taught you that,
I like
Horst?
to see.
Who taught you?
You actually. I like
That's right.
to see the device on profile, and that's not possible when you do it AP. Regarding cranial or caudal angulation in adults, when you look at the lateral view and you insert the wire into the left upper pulmonary vein, you can see that it is parallel to the surface of the table. So there's no angulation. So that's why I don't angulate during device deployment. I do not angulate cranially or caudally. But I go for LAO because I like the profile of the device.
Thank you. Dr. Neil, we usually do it in four-chamber view, that is 35 degrees LAO, 35 degrees cranial, because it is exactly equal to the four-chamber view on echocardiography, so it shows the best profile of atrial septum.
Mm-hmm. Okay.
And it makes it most uncomfortable for the transesophageal echocardiographer standing at the top of the table.
Unfortunately, we do not have transesophageal echocardiography. We do it under transthoracic echocardiography.
Okay.
That still makes it difficult for them to get near the table.
Okay, so can I release
Okay, Horst,
now, or?
have you released?
Yeah, no, you didn't allow
Yes,
me
please.
to release. Okay. So in order to release, I unscrew the red screw here. Can you see that? Okay. No. Yeah, okay.
We can see it very nicely.
Good.
And maybe
Okay.
a little closer, please. Thank you.
This is
That's
closed.
perfect.
This is closed. And now this is open. And now how to handle this here? There's always the question, should I push or pull? Actually, it's easy because there's just one way to do it. So when I push the black one, it doesn't go, so I have to pull it. And now you can see it's released. I'm just pulling it carefully back from the device because sometimes, as in this case here, sometimes the hooks are hanging up on the device. I will replay this here. Now you see the release. And now it got stuck a little bit on the wire mesh, but by carefully just pulling, and now it's released. Okay. So as mentioned before,
Horst, have you ever had one? Have
Yeah.
you ever had one that, despite loosening the red ring and operating the, how do you call it, the clamp, that you had one that was reluctant to release, and what did you do about it?
At least I don't remember. I don't remember that incident. Have you had that experience?
I think Gareth has.
Yeah, so it's happened to me a couple of times, and you just, if you rotate the cable, it tends to just flick off the ball. But I've had a couple where we're releasing the clamp is still just sat there, and I've certainly heard of a case where it was released and then it caught in the wire mesh and the device was inadvertently pulled out, like a bioptome would in the clamp. But certainly, if it does sit there, all you do is twist the cable around and it will pop off the cable.
It's worth knowing that, because
So
sooner
since
or
you
later
mentioned
it will happen.
the device attachment mechanism getting caught on the device, say for instance you had an embolization, can you use this delivery system to retrieve the device, or do you just shift out and use a snare or a bioptome? What would be your preferred method?
Well, I think it would be very difficult to grab this device with the delivery system. I think that doesn't work. So we never had a device embolization with the Occlutech, but if so, we would go for a snare, definitely. And you need a bigger sheath.
The ball's really easy to catch with a snare.
Is it necessary to measure the PA routinely after the procedure?
The PA pressure? Do you mean the PA? Did you say the PA pressure?
Yes, the PA pressure. Yes.
We don't measure this routinely during the procedure. We measure it later on non-invasively. And as I said earlier, in these elderly patients, when there's left and right, pressure goes down. It never becomes normal. So I bet it will go down to 50 or 40. But it takes a long time. It takes 6 months to 12 months.
Okay, Horst, I think that's a great demonstration. Thank you to you and Laura for that. We'll give you a round of applause, but you're coming back with another case, right?
Exactly, in about 2 minutes.